a professor of clinical medicine at UCSF and the director of advanced endoscopy at the VA. She completed her GI fellowship training at Stanford while pursuing her master's degree in advanced study and clinical research at the same time. I think at this point, we all know that Dr. K is well known for her relentless pursuit of excellence in the field. She pursued advanced endoscopy training at CPMC, and as if that wasn't enough, she went to Japan to get some extra training at the National Cancer Center. She was recognized in 2022 as a distinguished master endoscopist by the American Society of GI Endoscopy, being one of the youngest to join the ranks. Dr. Kaltenbach's research interests primarily focus on improving the quality of colon cancer screening and the development of evidence-based clinical practice guidelines. Throughout her career, she had led and participated in numerous randomized trial, observation study, and also consensus and guideline statement, including the endoscopic removal of colorectal lesion and colonoscopy follow-up. As if that was not enough, I don't know how she also find time to focus on the improving endoscopic teaching using adult learning with deliberate practice. She is currently completing a master's degree in health professions education at Johns Hopkins. She has directed simulation-based master learning hands-on and virtual training events around the world, and we are so fortunate to have her here teaching us how to perform a high-quality colonoscopy today.
Yeah. Thank you so much for the introduction, and it's a great privilege to give this presentation today on a topic that is familiar to all of us. I think as gastroenterologists and endoscopists, we're all invested in colon cancer prevention through colonoscopy and through high quality colonoscopy. So I hope we can share some great approaches today. I start with this. This was years ago, one of my earlier cases, and it taught me a lot, this particular case. Number one is I'm seeing an abnormality here with a thickened fold. So automatically it's getting into sort of detection techniques. And then how can I see that? So completeness of exam and the technique in that is really important. So in this particular case, the scope I'm using, the straightness of my scope, the ability to retroflex, to really see what I'm looking at. And then the scope itself is about 13 millimeters in diameter. So you can see as a reference, this is a small lesion under 15 millimeters, something I think that is really small, but using all of the skills that each of us have as endoscopists with the standard equipment to interpret what we're seeing, to look at the blood vessel pattern, to look at the surface pattern, and really to determine here that this is a lesion, even though small, that has submucosal invasion. This isn't like an isolated ulcer. This isn't a lesion that we should just put a snare on. This is a lesion that is concerning. And then the next step for sure is, where do I biopsy to prove that this is a lesion with deep submucosal invasion? And that's again where interpretation in real time is important, my decision making, and getting that central area to show that this was cancer. So this case, I think, taught me and emphasized the importance about being a thoughtful endoscopist, about having the techniques to allow me to do all those things very efficiently. That's not an edited video. And that patient, I biopsied appropriately, I tattooed the area, and then the patient had surgery to show a T1 cancer. So I open with that case just for us to reflect on as we go through this lecture about high quality colonoscopy. I want to also show us that adenoma detection is highly variable. So I think we're familiar with adenoma detection, all of us now. The number of colonoscopies performed with at least one adenoma out of all the colonoscopies that we perform. And so there's been established benchmarks for adenoma detection rates. And I think we're all recognizing that those are pretty low benchmarks as we do colonoscopies and get more data. We had the ability through the development of the VA colonoscopy quality improvement program to essentially be able to identify colonoscopy characteristics across the VA. This is an example that we presented recently to show with over 1 million colonoscopies performed by over 100 GI and surgery providers across the VA, that our adenoma detection range between 5 and 80%, and that for every 5% increase in the provider's ADR, that there was an odds of having a post-colonoscopy colorectal cancer decreased by 8%. So this echoes the data published by Corley years ago to show there is a direct inverse correlation between adenoma detection and protecting from colorectal cancer. This is a much higher number of colonoscopies and GI and surgery providers to show, again, high variability in the range and a consistently high protection the higher your ADR is. So I also show a slide. There's so much interest in colonoscopy quality and really that focus on detection. You could spend an entire career in only one of these small bullets looking at, withdrawal time, the type of imaging, when you schedule the patient, if a fellow is involved or not, if you use a cap, what kind of nurses are there, what preps. Like, there's so many things people look at that are trying to improve adenoma detection. And at the end of the day, it comes back to the operator. It comes back to us, the providers, and we are that definitive difference in someone's adenoma detection rate. And I want to emphasize that deliberate practice is really necessary, that we're not suddenly able to detect polyps. It's not necessarily an easy skill. We have a colon that needs to be clean. We have a colon that moves. There's teaching involved. There's a team involved. There's a patient with alarms and sounds. And we're doing a lot of tasks at one time. And so there's a lot of inputs to our mind that need to decipher out polyps. And this isn't something that suddenly becoming a gastroenterology fellow or an attending we're able to do without intentionally learning how to find polyps. We showed this years ago now that if you do train in subtle lesion detection, your adenoma detection rate goes up. We find both more flat lesions and serrated sessile lesions compared to a group of providers who were not trained in being intentional in searching for flat lesions or more subtle lesions. We also showed that we found less of the less important ones. So we focused on the important lesions like the neoplasias, and there were lower rates of sort of hyperplastic type polyps that were removed and found. I think the really encouraging news is that if as that provider, we can improve, so we don't have to be static in our performance. And this was nicely shown by the Polish group who publishes a lot on this topic, to show that if you deliberately train, practice, and implement these changes in practice, you can improve your adenoma detection rate, and moreover, you can protect your patients further from interval colorectal cancer. So I think we each can improve as individuals and as a system to protect the patients further. So I like to remind us of a mindset for lesion detection and everything we do in life. There's a mindset associated with it. And for lesion detection, that mindset is that we have to practice to get a reflexive recognition of these deconstructed patterns of the colon. And those are lines in the colon, vessels in the colon, and folds. And if we deconstruct the normal patterns of this, our minds will reflexively recognize abnormal. We also need to reflexively need a clean mucosa. So we joke that, the first year fellows can see through stool or bubbles because you're not inherently knowing that you need to wash those off. But that should become reflexive, that you see an area and you're washing it and looking. You also need optimal lighting. We have the capacity on an endoscope to change our lighting, to change the iris, to make it lighter or brighter or darker if it's too bright. So we need to be able to have the mindset that, again, things aren't static. You may be in a dilated area of a colon where the area is really dark because the light is distributed, and then you get to an area that you're looking and it's like bright white and you can't interpret it. those are things that you adjust the lighting. So be dynamic in order to optimize your inspection and reflexively do that. The light should reflect, you should be bothered by it being too dark or bothered by it being too light, not knowing you're bothered, but your mind subconsciously changes the light because you want to see better. And then certainly your insertion technique, needing to have it straight so that you're not focused on controlling the instrument. You're focused on that being natural and you looking. So your cognitive energy is spent looking for the lesions, not trying to keep your scope straight. And that's why we practice so much in the beginning of your fellowship on trying to manipulate the endoscope with that one hand and trying to get that to be reflexive so that you're able to do that subconsciously and focus consciously on these other things. We want to be efficient. So we talk a lot in the metrics about time, but how you spend the time is important in being efficient with that. Whether how we examine, how things are distended, how things are you're cleaning, those are all things that you need to be efficient in. And then lastly, have an algorithm. And that ties into efficiency too. When we're doing our exam, we need to have an algorithm that can be patient-based, whether you know to add a specific tool such as chromoendoscopy in patients with inflammatory bowel disease, where those lines may be harder to see or vessels may be harder to see because of the changes of inflammation over time, or whether we want to use a cap or more recently AI. These are all algorithms we want to incorporate in our mindset and approach for lesion detection. So let's start with just the basics. That split dose bowel preparation really is the cornerstone. I think that this is implemented in all units and is an important milestone and system. In addition to just saying it's split dose, how that is delivered and those instructions to the patient and that follow through is really critical. Protecting ourselves for sustainability, as well as in each case having optimal ergonomics established, that meaning the height of the bed, so it's not really at your shoulders and you're crunching over, or it's not too low and you're leaning your back over. Having the height of the monitor be appropriate so you're not looking up or looking down with neck extension. Having the processor in line with the rectum, with the anus of the patient and with the monitor, so there's that line there, and that all these things that are neutral and allow for optimizing ergonomics. And then again, going back to that straight scope, you apply minimal force from you when you hold the scope properly as it was designed to be held, shown in this picture from the engineers who developed these endoscopes, and then having the ability to manipulate the dials seamlessly are all important for inspection that tie into your insertion. So this is just a video here to show if in this particular case, there's some difficulty advancing the instrument. You can see the struggle, and you can see how if you can't control the endoscope well, all of your energy is going into that effort. And so you're not really going to be looking for polyps. So high quality includes a proper insertion, and then that ties into the inspection. This isn't something I'm going to go over other than to say that we've got a lot to go through when we see a polyp in our mind. And so the more we imprint in our mind classification systems such as the Paris with the morphology, classification systems such as NICE for polyp patterns, and systems that advise us and guide us into how we should manage polyps based on their size and histology. These are things we should review and practice again and again so that when we encounter it, again, it becomes reflective. So we create these mental maps in our mind of algorithms so that we can make proper informed decisions based on standard approaches. I hope in this lecture we can have some engagement from each of you. So if you could, on your smartphone, log on to pollev.com/acad of endoscopy. we'll have some interactive polyps to be found or not, so we can practice some during the talk. Let us know, Tiffany, if you can put that in the chat so I can keep going.
Okay.
Thank you. Okay, so we talked a lot about like creating these mental representations. One of those is the morphology classification, the Paris classification. And don't be intimidated by the 0, 2Bs, 2As, 2A, 1S. Like those things, I think people see that and they like automatically like don't even try to interpret Paris, but it's quite simple. And you basically have a polypoid section being pedunculated or sessile polyps, and a non-polypoid section being the superficial elevated, or colloquially we call those flat, and then the depressed. And the reason that we care about a classification system here is that the management of these lesions will differ according to their shape, and then how our mind primes to inspect for polyps is very different looking for a pedunculated than looking for a flat or depressed. So we're going to do a little bit of this deliberate practice in order to develop the start of expertise in finding these. Part of finding them is not just me showing you a bunch of polyps, but really deconstructing what are we doing in order to find the polyp. So let's start here. We've got some responses already. I'm asking, what do you see? And people are saying hyperemic patch. If you have one word, if you have two words in your responses, just connect them with an underscore, because the system puts every word on its own. So we're seeing reddish, hyperemia, and patch. Okay. Normal mucosa. Okay, but do more than that. Why is it normal? What do you see? Take it a step back and deconstruct. What does normal mean to you when you're looking at a colon? Lots of people are saying red, erythema. What's the erythema? What is it? Why is it red? I see white too. Maybe that's what the patch people are saying. So good. We're having lots of like redness, vascularity, hyperemia, vessels. So yeah, in this particular view, I think what's most striking is are the blood vessels, right? We're seeing the blood vessels, and our eyes are following those blood vessels, and they're definitely red, but they look normal. They're continuous. How about here? What do we see here? Edema, a normal fold. Okay, so we're talking about a fold here. Villi. Someone's seeing villi. That's impressive. Okay. Loss of something. So if you're seeing a loss, connect it with an underscore. What has been lost, so we can see that. Healthy tissue. Why is it healthy? How does your mind know that's healthy? What are the ingredients to normal? What are the components of healthy? Similar, so you're seeing uniformity. Okay, so yes, so good. This is also normal. So these last two slides are normal. And in this particular case, agree, what's showing most are the folds. In the last case, we saw a lot of the vessels were most prominent. In this one, we're seeing folds, and the start of I think maybe when you said villi, you may be talking about the actual mucosa, but agree. My mind here is following the uniformity and continuity of folds. I'm not seeing vascularity so much in this view. How about here? Lines. Yep. Normal line. What are those lines called for bonus points? Continuous lines. Great. I agree. They're very, my mind's following them. Uninterrupted lines. Okay. Agree. So in general, when we look at the colon, we're seeing those three features the most. We either, and depending on the lighting, depending on the patient, depending on the segment, some of these may be more prominent than others, meaning sometimes we really see the blood vessels, sometimes we predominantly see the folds, and then sometimes we can see the lines, and sometimes there can be a combination of these features. So this is really important as you do colonoscopy. The foundation of what your mind is looking for are these three things. And what we're looking for is the continuity, the uniformity, the homogeneity of these things. So we're seeing normal here. Once it's not normal, that's when we see a polyp because it's interrupted. Here we know that these lines are circular, so in that's a diverticulum. So we essentially imprint on us these normal features to then identify the abnormal. And we're going to prime our minds. So in addition to these three components, then what becomes abnormal? When the color changes and there's more redness, or there is this interruption of the redness or the vessels, when there's an interruption or an absence of those lines, which are called anominate grooves, if there's some bleeding or friability, or if there's a deformity of a fold or a wall. So again, we prime ourselves and learn about the normal in order to then identify the abnormal. So serrated lesions caused a lot of trickiness for everyone during colonoscopy because they're pale, they're often flat. They have this mucus over them that no one ever thought to wash off before, and they cause some trickiness in that regard and a challenge for detection. So the features of serrated lesions are all of those things. They're indiscrete borders. They have a mucus cap. They're pale without vascularity, and they have sort of a cloud-like structure. And how do we see this then? We see this from what I just described. In this particular case, our mind is following this vascularity that's most prominent here. And then suddenly that vascularity goes missing, right? Like you can see, why did that blood vessel suddenly disappear? And that's because there's a lesion there. So we're using the normal, the vascularity, the folds. This isn't on a fold, so we're not using a fold here. We can't see the lines, but we can definitely see these blood vessels. And then there's suddenly this patch of like absence of blood vessels. Well, we don't suddenly have an absence of blood vessels. And the reason that is because it's covered with a lesion. So we talked about the mucus cap, this rim of debris from the mucus. Instead of dismissing that as stool, we would actually be drawn there to look further. You can also see, again, there's suddenly an interruption of this vascularity. You see a very prominent vessel, and then it becomes much fainter because it's covered by a lesion. There's also these O signs. We see this in the small hyperplastics where they have that uniformity of the pits. We also see this sometimes, there's some prominence of this feature in serrated lesions. It's these dark pits. That's mucus in there with a very dilated pit, and those are also features of serrated lesions. So let's look at the pattern here. We're following the folds. We're looking at the blood vessels. I'm not seeing the lines so well here, but I'm following the folds. I was following the folds. Let's do it again. Following the blood vessels, following the folds, circular. We talk about that a lot. We're doing a circular inspection. And what was going on suddenly? Hard when you're not doing the procedure or holding it, but normal, abnormal. So my eyes were going in a circular fashion here, coming back, circular exam, spiraling back. And then as I did that, there's a bump in this fold, and that is a lesion there. We see the wall fold deformity. Okay, what do we see in this image? What's the most prominent feature here? Okay, good. Blood vessels, right? We see the blood vessels and we see the folds. So that's the problem. I think the most I see first are those vessels, and then it's a nice flow to the folds. We're gonna and then in this case, what are we seeing now? Suddenly the lines become more prominent, and our eyes pick up on that to follow the continuity of the lines. This is a reminder again, and sometimes when we show the lines with indigo carmine, that helps you see them more with the white light. So you can see here you can see the lines faintly, particularly between the 1 and 3 o'clock. NBI doesn't do the best at picking up on the lines. That's why it hasn't been shown necessarily, especially with older systems, to pick up for lesion detection as much. But indigo carmine, you can see it pulls into the grooves, and then when the grooves are interrupted, it doesn't pull, so it looks more red and lesions are easier to detect. It's the whole concept of why chromoendoscopy is helpful for lesion detection, is because it highlights the lines, and then you can easily see when those lines are interrupted.
Consent in 3.
So going back to our patient who had that thickened fold, there's that thickened fold now in a little bit more of an angle. There is even friability to it. And then coming back further, here was spraying indigo carmine to look at the surface pattern a little bit more here. But some of the indigo carmine, that redness caught my eye, and then you can see there was another lesion there. So things to think about. I think I'll skip this one for now. Okay, so let's do a little exercise where we're finding lesions or not. There are some normal in here. Does anyone want to click on the area where they think there's a lesion? Okay, good. So in this particular area, we're following again, it's a still image, so easier than when we're moving during the procedure, but you can see here the fold is smooth, and then the fold here becomes thickened, and we've also lost vascularity. So there again, there's an interruption in the blood vessels. You can see all the blood vessels, and then suddenly they stop. Blood vessels, they stop. And then that fold becomes thickened. So yes, that's a lesion there. Here, I would say, how about click on the area that contains a lesion and then click on the periphery of the lesion? How about that? Yeah, so much more confusing, right? The good news is our eyes are drawn to this area because of that prominence of the fold. It's definitely more thick in that area. I agree. It continues to look a little granular and thick as we go towards the 6 o'clock. It's unclear on that backside. There's debris there if there's still lesions, but I would say that serrated lesions are often, their borders are difficult to distinguish. Many times they have been shown to have up to 40% incomplete resection rates, even when people are declaring that they've completely resected it. So we need to be extra mindful of interpreting the borders of these lesions when we find them. So agree. In this particular case, I think the next slide, let me see, shows it even closer. Let's see. Yeah, a little bit closer, but of an image. You can see here now, it actually ends here going over, and then it extends up to this backside. All of that mucus on on the backside is actually part of the lesion. And then there's a second lesion over here. Why do I know that second? Because you can see normal lines in between. Do you guys appreciate that? So this is just happens to be a synchronous lesion there. Okay, so I'm gonna, and the redness is because I think that was suctioned. This shows nicely. You can see the O's. You can see the cloud-like structure. You can see these lacy vessels that are described. And even though there's some vessels, it's overall a very pale lesion. This is a nice type 1, high confidence, and this is a sessile serrated lesion. And again, we want to be really mindful that we get all of the lesion. Injection can be very helpful to then discern normal from abnormal. These inject really easily, these polyps, I think, and can help you distinguish the borders. How about in this lesion? I think I've shown this before, so at a minimum, those who have seen it hopefully have learned. And for our new exposed, I'm curious what we see. Okay, so we have about 10 responses. Let's see where people are looking. Okay, so yes, clicking lots of areas, but the predominance in this area here. Let's show why that is. So I'm going to go back actually to this other slide. I think I have to clear that, right? Clear responses.
Or click responses instead of show all.
Okay, thanks. And then clear responses. Oh, all right.
Yeah.
It's not wanting to work. That's okay. I'll show it in this next one. But the point I want to show is in this front view of the fold, it's very normal and continuous. And then when you follow that next one, there literally is, thank you, Tiffany, there literally is a bite out of it. Like there's no reason suddenly you should have this concavity of a fold. I mean, that's just not how our that's not the makeup of, you know, the muscle and the submucosa. There's no reason that there would be this fixed indentation. And so the only reason that would be a lesion or scar tissue or something, or you haven't expanded it enough with air. And so that's the other thing when we talk about air insufflation being too inflated or being too collapsed. It's again a dynamic process when you're coming back. This could just be that I need to inflate more air and then it will straighten out. But when I do inflate more gas, it actually demonstrates the fixed even more. So you can see here as we get closer, this divot is very present. And as we get closer, you can start to see a lesion associated with that. Let's move on to another example. Click on the area here that may contain a lesion. This is an example of one that this is either having a, let's not show the responses yet, if we can, Tiffany, until a bunch come in.
Can you click on image?
Okay, thanks. So I'll remember that for the next one. So in this particular case, either the patient's having a spasm or I haven't insufflated enough. So that's again, just reminder to us that we need those that technique in order to be able to see everything. So in this particular case, yes, despite it not being optimized with insufflation, when we follow these folds, there's suddenly a convergence of folds down here. And there's also a little more redness at the 6 o'clock where most of the clicks have gone. And I agree, like this right side, this is still part of the lesion. So great. I think on this left side, you may be picking up a little more prominence there, but I'm seeing lines. And so I think our focus here is that this is a large non-granular lesion here. So this is it in a little bit closer view. Some of the other features you can put in here that we see, but certainly we're seeing a deformity of the folds or wall, I agree, there's a reddish patch. There's an interruption of the lines. So you can nicely see lines gone. Nicely see these lines, there's no lines next to it. Why would this be so thick? Why is it connected? Why is it red? So all of those things draw your attention there. I think that for the interest of time, we're gonna skip. Maybe we'll just do a couple of these and then I'll move on. So you can click if you think this is normal or abnormal. I guess we can get through these in time. Okay. That was normal, normal vessels, normal pattern. How about here? Again, these are hard because it's one image, not a video. So that qualifiers there. Oh, look at that strip right down the middle. We'll show you a little, we're looking at the IC valve there, and then in the distance, the appendix. So this is a little tough. Let's do another. Case 3. Remember, lines, vessels, folds, lines, vessels, folds, lines, vessels, folds. Okay. Let's do this next one. Terrible image, right? So value taking a good picture. But here we can see those lines nicely. There's redness, but there's lines that go through the redness, right? So redness alone doesn't mean it's a neoplastic. And when we're talking about abnormal here, I'm speaking about neoplastic abnormality. Lines, folds, vessels. Lines, folds, vessels. Vessels, lines, folds. Okay, good. I think everyone nicely sees that lesion there. How about here? Okay. Normal, good. We're seeing normal. There's that underneath of the appendix. I mean, I think that could be other bowel or something, but from a mucosal surface, we're seeing normal lines, normal vessels. This has a little bit of melanosis even in the mucosa. Okay, just a couple more cases. Let's see. Okay. Normal, there were normal lines there, which was the most dominant feature. Okay, yes, there's that thickened fold, right in at the towards 9 o'clock. And I think there's 2 more. Okay, good. And so again, in a still image, you're starting to imprint, what do these lines look like? What does vascularity look like? And then you translate it over to your colon during colonoscopy, and then you practice it more and more. The more images you look at, the more comparing and contrasting of cases, the more models are in your brain to decipher normal and abnormal. Okay, good. You saw that redness, the interruption of the folds there. Okay, good. So between 10 and 11, there is the lesion over probably 6 folds. How do we see that? We see that because there's suddenly a disruption of the fold, and there's more redness there. Okay, I think this will be our last one for the example, and then I'll move on to a few more topics about the quality of an exam. Okay, good. Yeah, we'll finish with that thickened fold and interruption of the lines. So great, everyone. Well done with your participation. Let's move away from these exercises for now. I just want to get in the last 10 minutes. We talked a lot about serrated already, and we've talked about a lot of the different features. So that's the key for you as the endoscopist to detect is, oh, are these all the same slides going through? Let me just get out of here for a second to go. Or Tiffany, can you go to like the next one while I think we talked a lot. My point of that exercise and the main focus of this talk being that is as an endoscopist, it's really important that you are able to detect, and having that knowledge and skill set to recognize normal and abnormal is the cornerstone of detection. There's a lot of availability now with FDA approved artificial intelligence computer aided assistant devices for us to aid in colonoscopy, whether it helps to facilitate training is an unknown or impair training. If we can standardize interpretation, so it help us interpret polyps, whether they're needing to be removed or needing surgery, if it can make us faster, if it can help us in documenting, or if it can make it more standardized and increase reproducibility. So here, here's an example of, for example, we've deployed across the VA nationally AI systems for detection, and we have been all units within the VA have these systems now. And so as fellows, you should have some experience using these. You can see in this particular case, there's spasm going on. We see that a lot. You can't really detect much when that's happening. So either administer insufflate again if it passes, or give glucagon. And what's happening here is that there is a bounding green box that's highlighting that area over there that is serrated, and then there's another. So the systems weren't necessarily trained for serrated lesions, so their detection rates for those are variable. They've been trained on diminutive lesions, and that's really something that we need to be aware of, that these AI systems weren't trained as much for cancers and weren't trained as much for advanced lesions and weren't really trained for serrated. They may, in next software updates, be more trained for those, but they've predominantly been trained for small lesions. So you can see how that works. And let me go to the next slide here. So in this case, you can see we're doing a circumferential exam, insufflating. There is the bounding box that shows I'm turned to NBI and then near focus. And that is a adenoma type 2 of the nice with high confidence. So the AI may have helped us find that. I think it's important to note that it will only find what is shown. So the technique of mucosal exposure is very important in the procedure. There's been lots of debate about the utility and the advantage of AI because the studies have been completely on both sides of it being helpful or it not helping at all. The reds here show it hasn't increased compared to control, and the green studies showing that it has. So you can see a really mixed bag of studies. This has been in the past 3 years or so because it's a relatively new device. Medtronic is one of the FDA approved devices that's most on the market today. And you can see increases in some and no changes in others. In the deployment we did across the VA, we studied 42 sites that had the computer aided detection and had 97 control sites. This was with hundreds of thousands of colonoscopies that we studied, and we showed a 4% increase in facilities who had the AI assisted devices being used compared to facilities that did not. They had an increase of 4.1%. So we had a positive study for the use of AI. Again, I think that there's lots still to be determined about its use in training. But I think in particular in the VA study, we're showing a positive result in that. Another adjunctive device for quality may be a cap. So typically, what does a cap do? A cap allows this retraction almost to bring back a fold at a flexure so that this blind spot is less blind to you. And it allows for you to have a distance from the mucosa that is more stable and you can stay in focus. So it can facilitate that exam. There's also other cap devices. This is an example here. This is an example of the distal attachment device here being used. And you can see again, it just helps you pull back the folds. You can do everything you do without a cap most of the time. In this case, I'm retroflexing and then still looking behind the folds in that regard here. Endocuff is a cap that has been studied by lots of different studies. That's why there's even meta-analyses, for example, of 12 randomized controlled studies to show that it did help in lower ADR, in lower detectors. It did show significant improvements by about 7% ADR increases when using the endocuff. Here's an example of the endocuff. So what it is it has these phalanges on the side. So when you insert, they are collapsed, and then when you withdraw, they expand, and it then will bring the folds down. You can kind of see a little bit of it there, and it will bring the folds back as you come back. In patients who have more strictured sigmoid colons or diverticular disease, it is more fixed, and so you have to be careful inserting it through those. Those would be a patient population I would caution the use of this device in. Again, that the meta-analyses I showed that significant improvement in the low-level detectors. There were several studies in the last 5 years since that meta-analysis that continues to show some improvement, some significant improvements when the endocuff is used. This is just the newer device doesn't have you can't see the phalanges as much, and so it's a little it's a little easier to use than the previous one. Okay, and then lastly, where I want to end is that engaging in a quality improvement process is really critical for quality improvement. So if we're engaged and aware of how we're doing, we are going to be engaged and aware to improve. And that means a lot of us, I think we think we're doing a certain way, and then when we see our metrics, it can inform us. in a different direction, or we may be surprised or intrigued by some of the things we find. So this has been shown again and again that engagement and quality improvement programs can improve colonoscopy quality. That goes for seeing metrics in ADR, bowel prep, withdrawal time, and cecal intubation. It goes to being trained in the different detection techniques. I've been leading with Dr. Gowron from Utah, a national quality improvement program through the VA, where we had 75 sites enrolled across the country, and we did a randomized step wedge study with over 500 providers to say if we actually engage providers in quality improvement, does their quality change? We measure metrics of ADR, cecal intubation, and bowel prep, and we give them national benchmarks and then what their local hospital is doing to give as references. So they get these biannual dashboard reports, and then are also engaged in a shared learning, kind of similar to what we're doing now, but a little more interactive, where they ask questions. I give them different examples, and they are engaged. This is just an example of what they would see on their dashboard. So you can see it's highlighted. You don't see providers' names, but you can see your performance compared to your peers. And in this example, it's ADR on the left with volume. And you can see that certain outliers you would want to help identify, and we provide confidence intervals. And this data goes back on the dashboards to 18, but we have data going all the way back to the early 2000s. This is just an example how it really can change. This was a provider who really had been identified as having low ADRs. This benchmark being 30% with the society guidelines. The VA averages is 47%, so could reconsider the benchmark. But long story short, this fluctuating around 11, 13%. And then an intervention was made with the dashboard, and you can see a dramatic improvement. Certainly still ways to go to get to where the average VA is at 47%, but now meeting at least above benchmark. So to close, inspection tips for quality colonoscopy and lesion detection. We want to know those signature features of adenomas and serrated lesions. We want to do a systematic inspection of normal. Those are the lines, the vessels, the folds. So we reflexively unveil abnormal. And for the technique, a straight scope, a clean mucosa, looking behind folds, expanding and collapsing the lumen dynamically, wanting to take time, but we need to be efficient with the time. Be mindful of the time and what you do with it. And most of the time we should spend in the right colon, whether it's retroflexing for that second or going antegrade twice. That's an important component. Whether I do it with a fellow or you're doing it by yourself, you should do that second exam. And then the adjunctive tools is really the lighting, use of caps, use of chromoendoscopy, use of AI are important. And that engagement, always wanting to improve, having that as your mindset, and having formal quality assurance program with assessments and feedback are really critical to high quality. Thank you. I'm happy to answer any questions or comments. Otherwise, I think we're good then.